Ayushman Bharat. The scheme has been launched, no doubt, but still the benefit to the last mile is yet to reach.
What are the initiatives the government of India can take to address the healthcare needs of 1.4 billion people?
So in 2017, I will say, the first major step was taken in terms of new health policy. And 2018, what you just now mentioned, the world's biggest insurance scheme, Ayushman Bharat, came.
Right.
Which is covering 40% of the population under the cover of 5 lakhs rupees per family. Within next 2 years, government realized that although the scheme has been launched, but firstly reaching out to this population and giving them the cards is a tough job, number one. Number two, you need hospitals if you have to cover that population. And then they started realizing that they didn't have the tertiary care with the government.
Hello viewers, I am Colonel Parmar, your host for the inaugural session of Health Waves. I am one of the co-founders of AyushPay. In AyushPay, we have started a series of discussion with some of the stalwarts of the healthcare industry. Today we have with us Dr. Girdhar Gyani, one of the doyens of the healthcare industry. Welcome, Dr. Gyani.
Thank you.
So, Dr. Gyani is currently the Director General of AHPI, the Association of Healthcare Providers of India. He has also been the Secretary General of the Quality Council of India. And because of his sterling contribution to the upliftment of the quality, not just in the healthcare industry, but also in many other industries, is also known as the Quality Man of India. Dr. Gyani has also been the CEO of NABH, the National Accreditation Board for Healthcare Providers of India. Because of his phenomenal contribution, he has also been conferred with many prestigious awards and accolades. Welcome, Dr. Gyani. Your journey in the healthcare industry and otherwise cutting across the industries has been wonderful. Can you take us through your inspiring journey so far?
Okay. Thank you, Colonel Parmar. If I want to start, I would like to start with my journey from Defense R&D organization, because you are a Fauji officer from the defense. So let me start from there. I was appointed as a scientist at Institute of Armament Technology, which is Pune, where I was teaching the army officers or Navy and Air Force officers who were coming there for short-term and long-term training, including how do they work on high altitude or using the armament, various aspects of it. I spent 5 years there, and then on promotion I was transferred to Nasik. There is a HL and there is a DRDO unit at HL where actually they look into the quality aspect of the aeroplanes which were being manufactured there under the collaboration with USSR.
Yes.
Now that is the tenure of 10 years, which actually taught me how do you really build quality and reliability right at the design stage. And once I finished that, I then cross-migrated to Ministry of Information Technology. And they posted me first at Guwahati, which was a difficult station that time, in 1990, where Ulfa insurgency was at the peak.
Right.
And my job was to establish a biomedical laboratory, testing laboratory for the northeastern region. And there I was sent by government to UK on long-term training on quality. And there I picked up the specialization on healthcare. And there, once I came back after training from UK, that was in Nottingham, they appointed me as the founder director of the Indian Institute of Quality Management, which came up at Jaipur through the Indo-German collaboration.
Right.
That really is a transformation that from a defense R&D scientist and then into IT professional, and then I became the expert, or you can say the facilitator, and I trained around 15,000 people in area of quality across. And I can also tell you here that first 250 pathologists were trained by me at Jaipur, and who became subsequently the assessor for NABL. So that was my major entry into the healthcare. Based on my work at IIQM, I was selected in the open, as a Secretary General of Quality Council of India, which I consider as a prestigious appointment, because the role of Secretary General or the Quality Council of India is to establish the framework, quality framework, which comes under WTO. In WTO there is a provision that from country to country, how do you export the product, so that if I test the product here once, it should be accepted globally. So that is a role was given to QCI, and we established the accreditation standard for all management system, food safety, environment, education, across. And here in 2005, the opportunity came that the question was raised in Parliament, because a lot of medical tourists were coming to India in around 2001, 2, 3, 4. And they were asking one pertinent question, that how do they choose a hospital?
Yes.
And do we have any accreditation system in India? So this question was raised by one of the member of parliament. That was in April 2005. And this question from Ministry of Health was transferred to Quality Council of India. And I was asked whether I can establish a global accreditation system in India. So I picked up a team of 6 senior doctors, and along with, because I had training of how to establish the framework on quality, I guided them, and we came out with a standard in February 2006. That is the NABH, and we submitted it for international recognition to ISQA, what we call International Society for Quality in Healthcare. And we got it accreditation. Of course, it took another 1 year time.
Right.
But in the meantime, we launched the accreditation in India. And that, you can say, is the journey of healthcare quality in our country. And in first year, in 2007, I'm talking now, in February, only 5 hospitals could qualify for accreditation. Within 1 year, it was actually that time difficult for a hospital to understand what is all about.
So our quality standards were not really optimal at that point in time.
You can say that, and at the same time, hospitals were also not very prepared. And how do they implement and get accreditation? But luck would have been that our first 5 hospitals, we invited Dr. Abdul Kalam, that time President of India, and he actually gave the prestigious accreditation certificate to these 5 hospitals.
Excellent.
And that actually motivated the rest of the industry. Oh, President gave the awards, And I can see next year, of course, we were able to gradually increase. And today, of course, you see we have got more than 1,500 hospitals accredited. And around almost 10,000 also are certified, a lower standard of the NABS. So this actually journey I considered important because this has established, the culture of patient safety in our country.
Yes.
Till that time, I think we were just following the practices. Doctors were doing the way they were doing. Hospitals were not following any system. So a lot of medical errors were actually happening without knowing.
Yes.
So that actually has come to a halt now.
And this has also helped the medical value travel industry.
Oh yes, you are right actually. I can assure you, because now the patients come happily. They identify, okay, out of this 1,500, this is the hospital they want to go. Because they get the confidence now that they are going to a hospital which is not only accredited by NABH, but NABH is further accredited by international organization.
Right.
So our hospital accredited in India is at par with hospital accredited, let us say, by Joint Commission in USA.
Yes.
Same level.
So it is almost similar standards that we are currently following.
That is.
So, Dr. Gyani, we have also taken NABH across beyond our borders. Can you throw some light on that?
Actually, you are right. Actually, so what happened actually, after we operated the system in our country, Philippines was the country which approached us the first. But they didn't have any accreditation system, and they realized that establishing the accreditation, we took 1.5 years.
Right.
So, and they perhaps thought easy ways to invite India. So I went there and we signed a MOU and we launched our accreditation under the NABH International.
Right. And also in some of the SAARC countries.
In SAARC country, Bengal, Nepal, Bangladesh, then Nepal. In fact, I don't know whether people know about it or not. I was invited in Pakistan.
Okay.
In 2011.
Right.
And I trained about that time 100 doctors were there in that. I took along with me Dr. Sanjeev Singh from India, Dr. Zainab Zaidi. Actually, they were so happy. Then they took us to a few hospitals in Karachi. And they said, can you give this standard the way you have given to Philippines? I said, of course, it has to come through government. But for the time being, I can say safely that yes, we will give it to you. And they say, okay, please train our assessors. Everything happened.
Wonderful.
By the time I came back, and then subsequent visit we went to Lahore within 6 months. And then Ministry of Foreign Affairs were launching a arrangement that from now on professionals can visit each other country without any limitation.
Sure. So,
but because you are again from army background, so you will remember there one incident happened where they beheaded one soldier, our soldier.
Yes.
That incident created the environment in our country, and that file was held up. Otherwise, I tell you,
right,
our standard would have been in the Pakistan.
So NABH standards have not just benefited India and contributed to the cause of medical value travel,
yes,
but it has also helped our friendly
nations.
countries. So today a lot is spoken about the global south.
Yes.
So India is slowly emerging as a leader for the global south. Many African countries today are part of it. I'm sure NABH will also reach some of the African countries where the healthcare industry is still in the formative stage. So you've had wonderful, very diverse experience drawing from some of the best practices globally. It is helping transform the Indian healthcare quality ecosystem. So this brings me to the next question, about the current organization that you are handling, AHPI.
Okay.
What was the motivation behind the launch of this wonderful organization, and how is this complementing the efforts of the government of India in bringing quality care to the people of the country?
Okay. In 2012, I completed my term as Secretary General, Quality Council of India, which is a government organization. And then I took a small break of 2 months and went across to USA. My daughter lives there. And that time I got a call from India from Dr. Devi Shetty and Dr. Prem Nayak. They said that we have a small association of the hospital which run the DLB programs.
Right.
We want to expand it now across so that it covers entire health industry, because we have nobody here who can represent our industry with the government.
Right.
So will you be interested to be part of it? I said, okay, I'm coming next month. So once I came, we had a discussion in Bangalore. And finally I got convinced, I can be part of it. So we started, let us say from September 2012 and got this association registered as a society in December 2012. So this is a journey actually started 2012 and I'm still continuing there. So they appointed me as a member secretary as well as the director general, that is CEO you can call it.
Right.
I tell you, when I started into this role, because now I was on this side of the table, I came on the other side of the table. I realized that, for example, automobile industry, very well united. In telecommunication industry, they talk to each other. The healthcare industry was very fragmented. One hospital will not talk to another hospital.
So, AHPI really acted as a collective voice for the policymakers.
Yes.
To represent the interests of the industry
With the government.
and also offer certain suggestions about the improving the quality of care and bringing in efficiencies into the ecosystem.
I remember the first major thing which we did in 2014. We made a study that India at that time had 50,000 MBBS seats. That was our major study. And postgraduate seats were only 18,000. And we realized that without post-graduation, doctors have hardly any role. So these MBBS doctors were struggling. So we went across and we raised the slogan. That time, Pranab Mukherjee was the finance minister, and we made a presentation to them that unless you increase the PGC, we told them make them equal. Otherwise, we will not have, and this situation continued for next 4-5 years, and government had to admit in parliament that there were 80% shortage of the specialists in the community health centers.
Right.
Community health center is supposed to have one, gynae, one pediatric, one general physician, one general surgeon, and the 80% vacancies because
which would have been adversely impacting the primary health care.
Absolutely.
So the infrastructure as well as clinical excellence both were missing from the primary healthcare delivery.
Completely.
And this effort was aimed at addressing those gaps.
Yes. And today, you see, that effort they started realizing. And today we have got 100,000 MBBS seats and almost 60,000 postgraduate seats we have got.
So, if I may say so, that the transformation of the healthcare industry, kind of consolidation of the collective voice of the healthcare providers, improving their internal quality, everything was impacted with the creation of AHPI.
Yeah.
Wonderful. So
one more incident is Standing Committee of Parliament on Health. They invited us 3 times.
Excellent.
On various issues.
So how many members are there currently in AHPI?
Now we have got around 21,000 hospitals as our members.
Excellent. This is a huge network.
Yes.
If we have an internal dialogue, I'm sure it will impact the quality as well as the cost and affordability and access, to the last mile. As we see, Dr. Gyani, healthcare industry globally is the biggest industry, right? In the US, they are spending almost 20% of their GDP on healthcare delivery. In India, we are spending much smaller, proportion of the GDP, less than 5%.
Less than 5%.
And healthcare industry is also one of the biggest employers with almost 4.7 million people, large number of them women.
Yes.
And there is a kind of evolution going on of the industry. The government has set aside amount of 86,000 crores, almost $11 billion,
right?
For the healthcare industry, and there are a number of other initiatives like creation of those wellness centers, 1.5 lakh wellness centers, against which almost 1.6 lakh have already been commissioned. Step in the right direction, but really a drop in the ocean. So how do you see the future of the industry? How is it going to evolve? And what are the initiatives the government of India can take to address the healthcare needs of 1.4 billion people?
Okay. If I just want to go back, 1946, the British government at that time appointed a committee to study the healthcare system. And that committee made an observation that at that point of time, 92% of healthcare was with the government. Only 8% was with the trust hospitals. And they said that this should continue. The healthcare should remain with the government.
Alright.
Now, what has happened, because I have been part of government for long years, the first 30 years, the emphasis of government was on meeting the basic needs, what you call roti, kapda, makan. Basically they were trying to, build the nation that time. Next 30 years, if I want to say, actually they focused on bijli, sadak and pani.
So healthcare was still neglected.
Yeah, that's what I'm saying. You have correctly said.
Right.
Only, I think, after 60 years, the focus has now started going on the healthcare. So that is why, if you see, somehow I think government thinks that if the infrastructure they build fast, the way they are doing now also, I think overall it will help even to bring the healthcare and education into the limelight. So in 2017, I will say, the first major step was taken in terms of new health policy. And 2018, what you just now mentioned, the world's biggest insurance scheme, Ayushman Bharat, came.
Right.
Which is covering 40% of the population under the cover of 5 lakhs rupees per family.
Right.
Now, if you really ask me, because when this was launched, I was invited in Frankfurt because there was a big conference. They say, we want to listen from you how a poor country like India can afford to provide healthcare 5 lakhs rupees to the 40% population.
Right.
Anyway, I, with my own way of made a presentation. So that is one major breakthrough. Within next 2 years, government realized that although the scheme has been launched, but firstly reaching out to this population and giving them the cards is a tough job, number one. Number two, you need hospitals if you have to cover that population. And then they started realizing that they didn't have the tertiary care with the government.
Right.
Our data of association, we have worked out more than 85% of the tertiary care beds are in the hands of private sector. So any procedure coming under tertiary care, the Ayushman Bharat beneficiary has to depend on private.
Yes.
And private sector, I think you know it, that we have only presence in tier 1 or some in tier 2 down. Nothing in tier 3, nothing in the rural area.
Right.
So the scheme has been launched, no doubt, but still the benefit to the last mile is yet to reach.
So that brings me, you made a very valid point. That currently almost 2/3 of the India's population still resides in tier 2-3 cities and
Rural area.
And the healthcare delivery there currently is abysmal. AyushPay, my own company, has been operating in tier 2-3 cities.
Okay.
So up to secondary care, healthcare delivery is available in tier 2-3 cities.
Yes.
And primary healthcare is still a lot to cover. The delivery is still very, very suboptimal. And this is going to impact the productivity and the health of the population at large. Today we are vying to be the third largest economy by 2027.
Yes.
So you've been operating in some of these smaller cities and rural areas, and some of the hospitals of these 24,000 that we just mentioned, they have been empaneled. A lot of them would be in tier 2-3 cities also. So what are the major healthcare delivery gaps that you envisage, which are there in tier 2-3 cities and rural areas, and how can the government and the private players really help bridge that gap?
Okay. So if you see, after independence, government had a good setup. Around 24,000 primary health centers, 1.5 lakhs sub-center which you mentioned, which now are operating as a wellness center. Around 6,000 community health centers, and close to 800 district hospitals, and medical colleges. All that under the government was functioning. The issue which we didn't realize, we didn't have the doctors.
Right.
Any number of primary health centers even today, we do not have the doctors.
So capacity building is one of the problems.
Major thing came that number of, you see here
doctors,
again,
nurses and allied healthcare staff.
Nurses, actually we have around 1.7 nurses per 1,000 population. requirement is 3 nurses per 1,000.
Right. So
Okay.
right now, just to brush up on those statistics, Dr. Gyani, we have around 2.3 million nurses in the country.
Okay.
Almost 6.5 lakh nurses are working outside the country.
Outside.
There is still a shortage of about 2 million nurses.
Absolutely.
As far as the doctors are concerned, we have about 1.3 million allopathic doctors, about 6 lakh plus Ayush doctors. But against a budget of 1.5 lakh wellness centers, we've already commissioned 1.86 lakh
Yes.
wellness centers.
Yes.
Are they adequate? And our primary healthcare delivery is still suboptimal. We are still relying on the episodic management of the diseases. We do not go to a doctor unless this situation becomes critical and you require a major surgery because of a major ailment. India sitting on a chronic disease time bomb, you are well aware of it, and primary healthcare will be able to sort it out. So how do you think we can bridge that gap? Wellness centers, yes, government has actually exceeded its own expectations of 1.5 lakh wellness centers. What more can be done? Because currently the investment of the private sector is absolutely negligible in the primary healthcare delivery. Mainly is the government effort which is going into private, into the primary healthcare delivery.
Okay.
So large scale screening of population, is required so that the diseases are detected early and we can carry out the required surgical or medical intervention. Maybe lifestyle changes. If we know that this person is likely to suffer from these, there are a lot of technological solutions available which can predict, based on longitudinal data of the patient, what kind of an ailment a patient is likely to suffer from. Which are the other measures you think the government of India can take to address the other prevailing gaps in the healthcare delivery?
Okay. When you mentioned the word preventive health, you see, we made some study on this one, and we also got a detail from the studies done in other countries. We came to the conclusion that if you spend 1 rupee on the preventive health care, it can save you 5 rupees on the curative health.
Excellent. That speaks a lot.
Absolutely.
And this underpins the importance of preventive health.
And now, if you remember, that 2 years back, even government realized this point and they allocated 30,000 crore extra in the budget only for sanitation, drinking water, and the clean, care and, nutrition.
Right.
Now, to utilize this 30,000 crores is not easy.
Yes.
You need NGOs, you need people who can work with the local government, who can work with the Gram Panchayat to convey this message across the population in that area.
So increase the awareness among the population.
If you can do that successfully, which efforts are going on,
right,
I can tell you, your half the problem could be solved, because as you said himself, the preventive means that people are not coming for the curative.
Right.
Now, to avoid that, to solve that, this is the concept of the wellness center. That 1.5 lakh sub-centers were converted into the wellness center, which now, as you said, 1.86 lakhs already are functioning.
Right.
But here, let me tell you again, at all the places we do not have doctors. No. We have trained nurses to be the in charge in these sub-centers. No problem.
Right.
If you can connect them, which we are doing it, with the technology, with the nearest district hospital or the community health center, and if the nurse is able to, communicate the details of the patient, what the minor facility like X-ray will be there, they are trying to that, even a CT can be there. So if you can transfer the images and consultant can advise whether the patient is required to be shifted or he can or she can be treated themselves.
So what you're saying is that the technology can be a major enabler.
Absolutely.
So in teleradiology, this is precisely what we do.
Yes.
You scan the images and send them through the net. We have the cheapest data in the world today.
Yes.
And the internet has penetrated right down to the last mile. So if you can transmit that data to a specialist sitting in a partner hospital, let's say Ayushman Bharat is covering this entire ecosystem, and there is a partner hospital which is part of the Ayushman Bharat,
Yes.
and there is a radiologist available,
Correct.
or a technologist available who can read those images remotely and advise the patient. Either the patient is good, there is no ailment, or if there is any indication, then a suitable intervention can be carried out.
When you said radiologist, today we have only 18,000 radiologists in our country.
So the capacity building is one of
Again required. You see, 18,000 in the entire country. I can tell you, you have worked in the healthcare industry, the pregnant woman, we need to do ultrasound 4 times. Okay, at least 3 times.
Right.
Now tell me, rural India, if the women are there, there's no radiologist available who would work in the rural. So this teleradiology again is the answer. If the trained nurse can do the ultrasound, transfer the image here, and radiologist sitting here can actually decide whether the fetus is in the right position or we need to shift.
Right.
So a lot of things can be done, and technology. And by the way, here this National Digital Health Mission,
yes,
launched by government, is I think is going to solve many of the issues. Only thing we have to fast track this one. So till you have enough number of doctors, till you have enough number of beds, I think I forgot to mention, I think maybe you mentioned 20 lakhs beds we have, and you need 50 lakhs beds.
That's right.
So now more than double the number of beds are required. So it is a huge task. So it may take us 5 more years.
So another challenge, which the shortage of the doctors,
And
especially the super specialists, will always remain.
Yes.
In the UK, they have prescription nurses. So what if we improve the skill set of our nursing and allied healthcare staff? They can mitigate this critical shortfall among the clinicians. So, is there something which the government of India thinking on similar lines?
Contemplating. You see, the Indian Nursing Council has been restructured now. And for example, you said physician nurse assistant.
Yes.
In anesthetic, we are trying to train the nurses. 2 PG courses have been launched so that they can actually do anesthetic and physician
This is a
assistant.
wonderful initiative.
And presently, you will be surprised. Actually, I want to tell my viewers here that today a nurse officially cannot prescribe even a paracetamol. I think what are we doing? The nurse is 10 plus 2, then 4 years, and she becomes the BSc nurse.
Right.
And if you are not able to utilize her in prescribing a paracetamol, then what is this we are doing? We have made them simply bedside staff, you can say.
Right.
So I think gross underutilization of the nursing staff, if we can really slightly,
Increase their skill set,
that's all.
and maybe entrust them with more responsibilities.
So the shortage of doctors can be compensated to great extent.
Sure. So, and the clinician still retains, any intervention or surgical or medical procedure, which, if required, the patient can be, put through that in the hands of a skilled doctor.
Yes.
But other than the surgical or major medical procedural interventions, nurse should be able to take care of some of these issues. So I think we need to improve the skill set of the nurses and the other allied healthcare staff so that they can free up the doctors and
For the lower end jobs.
Absolutely. So that brings me, to the next question. The COVID pandemic really proved to be a wake-up call and proved to be an inflection point for the healthcare industry, really. If you see, most of the hospitals ran short of beds, medical devices, critical medicines, life-saving drugs and equipment. We did not have these, and patients were lying outside the healthcare facilities dying. So you just mentioned that we have around 2 million beds, whereas the need is of about 5 million in a country of 1.4 billion people.
Yes.
What if a pandemic of this scale strikes again, and we have not seen the last of the pandemics yet?
No.
There will always be pandemics. If we see historically, every 5 to 10 years there is a major pandemic afflicting people at a large scale globally. So even 50 million beds may fall short, right? So how has this COVID pandemic really impacted the industry? What are the new changes? What are our learnings? What do we need to do? Such a big country, rapidly growing, we need to maintain the health and the productivity of the population in the times to come. So, what are those interventions required at the government level, which will address this situation in future? And what are those technological advancements which we can partake of or implement in future so that we are a healthy country?
You see, this pandemic was the worst period even as an association. I was appointed as the industry coordinator during the second phase.
Right.
Entire industry. So I was coordinating with the government, shortage of oxygen, shortage of beds, communicating protocols from ICMR to hospitals across. Very difficult job because ICMR and AIMS were changing the protocols every second day because even they were at loss to understand how the virus is
because we did not have the knowledge.
No.
And this was globally the problem.
But disseminating information to tier 2 and tier 3 towns was a difficult job. Anyway, whatever we could do, we did it. But I think based on our COVID, we did one major study, which I want to share. Actually, I have not shared with the media so far.
Right.
That disparity in the bed density in our country. Now, I'll give you simple data. Karnataka has got 4.2 beds per 1,000 population, highest in the country.
That's huge.
You now see the Bihar, 0.29.
Much below the WHO norms.
No, WHO is 3.5.
3.5, absolutely.
They have 0.29.
Which is very low.
Can you understand? Now, this is Bihar. Similarly, of course, other places, somewhere we have 0.7, some have got UP, for example, has 1.5, some have, Kerala has got 3. Now, this was eye-opener when actually I discussed with our Niti Aayog also. Actually, I have now given my report to them also. But this will help our government to focus. Nobody is talking about it that Bihar is so poor. That's why if you see all patients from Bihar, they only come to Delhi. They go to South, they go to, CMC, Vellore, I don't know wherever to go because you have not catered. So I think this great imbalance is a factor, number one. Number two, a study which we did, that of course we did before COVID, that for example, Telangana, we found there are 125 hospitals which have 100 bed and above. 100 bed above means they will be around tertiary care.
Good quality hospital.
125. Out of which 112 hospitals are only in the Hyderabad, Secunderabad. So you see again the imbalance. Right. That means rest of Telangana, the tertiary care, all people have to come to Hyderabad. I think we should have regulated long back that if per 1,000 population, if you have got so many beds available, we should not allow new hospitals to come into that. Allow them to go to other districts. That is what now UP is doing. Each district they are opening the medical college.
Right.
So something similar, I think the COVID made us to learn. Of course, rest of things, the technology government started allowing that time teleconsultation.
Right.
Till that time it was not legal. Now it has become legal now. And I think our doctors have become
and there is a
technology savvy.
Place.
And third thing which you asked me, we have learned is the home health.
Home health care.
Now we are advising our hospital to open a vertical within the hospital home front. So if you have about 100 bed in the hospital, you can have 500 bed across in the homes.
Absolutely. The aim of the healthcare itself is to treat a patient well away from the hospital.
Absolutely.
And the patient should come to a healthcare facility only for surgical
care,
procedure.
ICU and all that. You're right. So now, but again here, you need allied healthcare workforce. Because we don't have the allied healthcare commission in the country.
Right.
No council. Only recently council has been constituted, which still is not functioning. So you have the Medical Council of India, which is now NMC, and you have got Nursing Council of India, but nothing for allied healthcare. This is a big gap.
Right.
So you get people trained or untrained here and there. on various standards, working in the hospital.
So I think we needed it the most during the COVID pandemic.
Yes.
So this is one area which the government of India has to really build, maybe in conjunction with the private industry, because currently the major players are in the private industry.
Yes.
The investment from the government, the improving the level of skills of these allied healthcare providers, rightly pointed out by you, is not up to the mark. And maybe scale it up across the country. I mean, before we hit the
AHPI, again, the role I'll tell you, the Prime Minister launched the scheme, COVID Frontline Barriers.
right.
So, at that time, AHPI was the only body, let me repeat word, only body which trained thousands of frontline COVID warriors through 3 months training, quick training,
Right.
on job, online. We designed the course which was transmitted and the people were made in charges in the hospital. So anyway, this is the kind of job which we did at that point of time, but now actually we have learned hard way. Efforts are now on to increase all these aspects, number of beds. And one aspect which we have submitted to the government is that for opening, I reminded government rather that Prime Minister wanted 3,000 new hospitals in tier 3 towns.
Right.
In 2018, he made a statement.
So was that government hospital or
No, he said private.
private?
Now we are telling that how can we open unless you incentivize?
Correct.
So state government, we have submitted a demand that you give us free electricity, subsidized electricity. Today, hospitals are being given electricity at the commercial rates, cinema hall and
Absolutely.
like that.
Absolutely.
Secondly, we told them give us single window clearance. Thirdly, we said give us soft loan, maybe 7%,
Maybe land at subsidized rates.
like international financial
Viability gap funding,
something like that.
because hospital industry is very highly capital intensive. You have to spend upfront and then start the facility.
30 lakhs per bed in the small town and up to 90 lakhs in a bigger town per bed. That is the cost of establishing.
And it can be much more in a big city like
in Bombay and Delhi. So these demands we have gone, they are considering it now, because unless you have tier 3 town having tertiary care, you will not be able to achieve the goal of universal health coverage.
Absolutely. So, we discovered that both the central government and the state governments have concurrent responsibilities as far as the healthcare industry is concerned. As we know that currently our health spend is very low. US spends, like I was saying, 20%, which is likely to increase to about 25% of their GDP.
Yes.
Right? It can have both sides. Either the industry is so inefficient that they have to spend so much. Conversely, they place so much of importance to the healthcare that they want to spend that kind of money. Our spend is around 5%, and most of it from the private industry, right? So, what are the other areas where the government of India and state governments need to pitch in to really take care of the healthcare delivery, this abysmal delivery which is currently prevailing across the country?
You see, the few things we have already discussed. That if you focus on preventive side or promotive side rather, I think before preventive, promotive. I think a lot of things can be sorted out.
Right.
Second, whatever you use, technology or education, you need at least basic infrastructure across the country. Basic blocks, where people can go. So you need number of beds be decided 20 lakhs to 50 lakhs you have to do. So investment has to come. Now, if I am the government today, I would be smart. I will not invest through capex because I will save that money for my other.
So PPP could be one of the most.
I can provide land to the private sector.
Right.
Private sector, I incentivize through the cheaper electricity, cheaper loan. I am telling you, there will be a huge investment coming, but only one small stumbling block is there. That private sector is asking that even if I invest, where is the doctor? Where is the doctor who is ready to come to tier 3 town?
So we identified that the capacity is really one of the major challenges.
Yes.
So Government of India has started certain initiatives, conversion of a district level hospital into a medical college. What are the other initiatives which you are aware of which the government of India is taking to address this major problem?
Now, the only other method is use technology. Telemedicine is already being used, but still we are not reached to the last mile.
Correct.
Okay. Then you have to, as I said, train the nurses. Like in USA, registered nurse. Mostly their primary centers, if you go to USA, they are managed by the registered nurse.
Right.
So you upgrade the nurses to handle those things and gradually increase the PG seats or number of specialists through colleges, through our DNB program.
Right.
Fellowship, diplomas, you do anything.
In the industry, we are using a lot of A&M, GNM nurses also, and slowly there is a shift towards BSc nurses or MSc. So at some point in time, GNM nurses and A&M will go away, and you will have only
BSc.
Nursing colleges, so BSc and above, because that's the barest minimum requirement. And I think we'll have the required capacity or skill set to take on some of the low-end clinical jobs like prescription of medicines.
You mentioned, I think I want to interrupt you here. You mentioned that so many lakhs of nurses are working abroad.
Yes.
I am advisor to the National Skill Development Corporation for the international placement of our staff, our healthcare workers.
Right.
I was myself surprised. Huge demand has come from US, UK. Next 3 years, 100,000 nurses are retiring. This is official
From the
data.
UK, NHS.
100 NHS.
Right.
So now they are looking into India.
Wonderful.
And so I think good market for us. But the problem is industry is asking NSDC and ourselves that we have shortage here and you are planning to set them there. So I can tell you here that emoluments which we are giving to a BSc nurse average is less than 20,000.
Pound sterling?
No, in India.
In India, yes.
Less than 20,000.
Yes. Entry level is just around 13 to 14,000 rupees per
And how much
BSc
we
nurse.
pay? How much we pay to our driver? My own personal driver is drawing 20,000 here.
Absolutely.
So this disparity is driving nurses to go out.
Right.
So I think now when you ask the captains of the industry, you have been the CEO of the hospitals, they tell you simple point that viability of running a tertiary care hospital, more so when it is dependent on the government scheme, that means beneficiary coming from Ayushman Bharat, beneficiary coming from CGHS, ECHS, ESI, the reimbursement rate is so low.
And the tariffs are also absolutely, ridiculous.
Yes.
So, I mean, the problem can be mitigated if the tariffs are brought in line with the industry norms. We can definitely pay the nurses more while retaining the profitability, functional profitability.
This is where I think we are stuck now. So one of the suggestions which has been given to government is that start co-payment scheme. That if you do not have money to raise the level rates of the procedures, okay, let patient pay portion of it to the hospital, so that hospital is able to get the operating cost. So that suggestion has been given by AHPI and maybe government is working on it. But overall what you said, nurses, the issue is that they are going to be a huge, I tell you, they will be going abroad. Netherlands is asking, Germany is asking, Canada is asking, Australia is asking.
So this actually shows the confidence.
Of course, yeah. The one way it is good.
Like, we are exporting some of the workers for Israel. 200,000 workers are, going to Israel for working in the construction and other allied industry. So we do have trained staff, but we need to pay them adequately.
Younger generation is available. That is the benefit of India.
Yes. So both can coexist.
Yes.
While we are exporting trained manpower, we can also generate our own in-house adequate staff. So really speaking, all this needs money, right? So the current spend on the healthcare delivery, $11 billion and less than 5% of our GDP, is it adequate? What more does the government need to do? Bring in private sector, because currently in the private, in the primary care, the investment of the private sector is almost negligible. Secondary care, there are smaller hospitals available from the private industry. Maybe tomorrow the district hospitals and others are adequately developed, they will be able to provide good quality treatment, but then they need the trained staff. There is still inadequacy of trained doctors in the government hospitals. Super specialists are not available. So they cannot carry out tertiary care, quaternary care surgeries, which you so critically need. So what are the other funding initiatives, maybe PPP, use of technology, such initiatives the government of India should look at?
Let me bring it here a point. Today, major chains of the Indian health, I will not name them here, they are all running with the foreign money.
Right.
FDA. Why? Because these foreign agency, they get, let us say, 4% return or interest rate there. Some countries only have the 2% interest rate.
2-3%.
So they are investing here and at least getting 6 to 7% return.
A lot of PEs are investing, like Blackstone, TPG.
Yes.
They are acquiring bigger hospital chains. We all know that. Temasek from.
Correct. Now, so this is one way that you open up little more. Although I personally do not consider that our healthcare should be running with the foreign money. But anyway,
Right.
let it be there. Second is that private sector still, let me tell you, has money. Other day, our Minister, Mr. Gadkari, was talking in that seminar that there's no dearth of money for any infrastructure. No dearth. And he's right. Only thing is, you see, the private investor, if he has to open a hospital, if the same money he puts into a, let us say, hotel. If he says that here my return of investment is coming in 3 years and here is going to come in 7 years, I think naturally as a businessman, he will like to put the money here. So I think we have to restructure our industry in such a way that we incentivize the private sector. You see, private sector still will invest in the hospital, even if he's getting less return, but at least should be able to run it profitably.
Right.
So, as I said, same thing, cheaper electricity, cheaper land, cheaper loan, single window clearance. If these initiatives you bring, parallelly you increase the supply of the doctors.
Right.
And corresponding infrastructure in tier 3 down, so that doctors find comfortable to serve there because his family and other needs are there. So this, I think, composite scheme or initiative will solve, which I am sure now government has understood.
So what you are saying is that while we get the foreign funding, like some of these PEs are getting, so that money will get reinvested because that money comes to our hospital
Yes.
promoters, and that we can invest in other cities, maybe tier 2-3 cities also. Maybe some of the PPP projects with the government of India can launch in conjunction with the state governments.
Okay.
Some concurrent investment from them will definitely, by incentivizing rightly the private providers, so that there is a clear line to profitability, because hospital industry is by definition capital intensive. You have to invest upfront, and then it takes many years for your investments to really fructify, break even, and maybe payback periods are longer. But imagine a hospital provider investing so much of money in a tier 2-3 city. How long will it take for that provider to really recoup the investment, get the required ROIC or ROI on that particular investment? So right kind of incentive for the private players
To invest.
build capacity in terms of clinical excellence, aligned healthcare staff, and infused technology.
Yes.
Telemedicine,
These are-
telehealth, remote ICUs. A lot of doctors are actually, these bigger hospital chains are sending doctors, to their, outreach clinics in small cities, so that the patients can be seen right at their doorstep regularly, and you are aware of that what the hospitals are doing. But having well-defined ecosystem in tier 2-3 cities and rural areas, right incentivization of the private provider networks will definitely yield with the right technology in bringing up the healthcare delivery to the last mile. Now there are new startups coming, Dr. Gyani, like my own company AyushPay.
Yes.
we identified that primary healthcare delivery is one of the major challenges. We need to screen our population. 2/3 of the population is still not getting the required screening, and there are a large number of patients suffering from hypertension, cardiac problems, COPDs, and other NCDs, right? And this burden is likely to increase and have its impact on the economy as well by bringing down the productivity. So my company is partnering with small hospitals, empowering them for reimbursement, extending medical loans to the patients. We've also recently launched our health cards, which is going to contribute in a big way in ensuring primary healthcare delivery. So preventive health or preventive medicine that we are so talking about, these days, my company is actually investing a lot of time, resources, and money into building a comprehensive preventive health ecosystem. There are any number of large, startups which have come, e-clinics, e-pharmacies, e-diagnostics.
Yeah.
So how do you think this new play of the healthcare, new age startups is going to disrupt the industry? Because government alone cannot do it.
I think you are doing the job actually. Sometimes that people do not know many of people. But let me tell you, we have close to 40,000 small hospitals which have less than 30 beds.
That's a huge number.
Yeah, and this is the hospital which actually is close next door to the community.
Right.
And what you are doing is I think can big impact on the health outcome. I think your company can also think of enabling these small nursing homes in using technology, maybe smaller way. Maybe, for example, there is no CT machine in the small nursing home, and if the patient with a stroke goes there, I think he's getting lost.
Right.
So I think you are supplementing the capacity or the paying capacity of the patient on one hand, helping small nursing home to give the treatment or the healthcare to the population. But similarly, you can add on this component of supplementing the small technology part. For example, in a small place where there are, let's say, 5 nursing homes, you can install one CT machine, and that can serve the all 5 hospitals. So I think this is what I call unsung hero. Your kind of organization is unsung hero today. So we need this kind of startup, and technology startup in any case are coming in a big way, let me tell you. A lot of youngsters are coming. I think we have got list of at least thousands of startups.
Right.
So awareness in the healthcare, government emphasis on the healthcare, actually all these things put together, I'm sure, by 2047, what you were saying, India can be on the top of the world in the healthcare. I am sure about it.
Right. So, we were talking about the Ayushman Bharat, Digital India. We have the cheapest data, internet data in the world right now. And Government of India has come up with Ayushman, with Digital India, National Digital Health Mission. Under Ayushman Bharat, we have launched ABHA cards, right? So, Aadhaar card created a whole new ecosystem in the country. Every government scheme and every benefit to the beneficiaries was dependent on the identification of the patient through Aadhaar card. So a lot of redundancies have been reduced, a lot of fraudulent cases have been curtailed, a lot of phony schemes have been weeded out, and the leakage has been curtailed to a large extent. Today there is a need for building that comprehensive ecosystem for the patients. So Ayushman Bharat Health Account Card, or ABHA card as it is called, is really going to be the disruptor in bringing quality care. And we often talk about interoperability.
Oh yes.
Between the various systems, a patient goes to a hospital, his ABHA card carries all the required patient details, a patient history. The patient goes to Delhi, registers for a particular OPD, and the patient has to travel to Trivandrum tomorrow. Same data accessible as per the required protocol, or he goes to anywhere outside the country, also accessible as per the required protocol to a doctor or a specified healthcare provider who can extend that treatment, surgery, medical procedure, this is going to be really a big disruptor. All right, so Ayushman Bharat can also be a precursor to value-based care.
See,
Is there? So, how do you think it will evolve into, universal health coverage?
I tell you, this ABHA card you mentioned. The ABHA card effectiveness will come when our hospitals also are maintaining EMR, EHR.
Right.
Now, how many of the hospitals are maintaining EMR? Very
Yes.
few. So, the National Digital Health Mission through National Health Authority will be AHPI is the partner now.
Right.
192 hospitals we have given to NHA to launch the pilot project. So, through that, all doctors working there, all facility and EHR will be brought. Once this model succeeds, it will be replicated across.
Right.
Because ultimately, we need directory of hospital, nursing home, chemist shop, doctors, and patient ABHA card.
Right.
That will make the complete ecosystem. So, actually, if you can do it in next 3 years, which is a little ambitious, but I think we can do it. Because India has one quality. It will be sleeping, but once it wakes up, I think you have seen
So, a lot of people had doubts about Aadhaar card when we were implementing it.
Yeah.
And today, every country wants to really replicate the system and UPI, success of UPI.
We are leaders world over IT.
Yes.
So why can't we use IT in our own sector, health, which now we have started. So I think our future is quite bright. I am very confident. In next 3 years, once the National Digital Health Mission completes, I think our major, and by the time, of course, our medical graduates will increase,
Right.
private hospitals will increase, they reach 3 towns. So 3 to 5 is a very crucial period now,
Yes.
which can make India, what you said, universal health coverage.
Yes. So, the value-based care, it's big in the US. So, thankfully, under Ayushman Bharat, we have already onboarded thousands of hospitals.
Yeah.
Still a very small number, but I'm sure, gradually this number will increase to increase the access and penetration for the patients in tier 2-3 cities where really the number of hospitals onboarded are lesser. So, under the value-based care, the hospitals will be measured on certain quality parameters. You have been, big into the quality initiatives, and that's really helping the cause of Ayushman Bharat and in future the universal health coverage. So the hospital need to have measurable standards. I when I was the CEO of a particular hospital, which is one of the biggest multi-organ transplant centers in the country, we had a team which came from, the University of Southwestern in the US. That's one of the biggest lung transplant centers in the world. And these people carry out, close to 100 lung transplants every year. And we wanted to build those standards. The hospital was already carrying out lung and heart transplant. Liver transplant, we were carrying out more than 20 every month, 8 to 10 kidney transplant, pancreas, and so on and so forth. But the hospitals really, to measure their quality of outcomes, need to publish data. 1 year survival rate, 2 year, 5 year, 20-year survival rate, and many other parameters based on which we can assess a facility. And Ayushman Bharat should really incentivize hospitals with good outcomes. Otherwise, quality will remain only nomenclature, not in execution. So, what are the other parameters you think the hospital should be asked to measure, monitor, so that they can be accordingly incentivized by Ayushman Bharat if we have to graduate onto universal?
USA, there is at least 4 insurance companies I know about. They have set up 2 things. They have appointed
HMOs, they have.
Yep.
Healthcare maintenance organizations.
Correct. You are right. So they have, what they do is, through independent organization, they measure, for example, they give patient feedback. When the patient is admitted, during the treatment, at the time of discharge, and 1 month after discharge, they take feedback. Based on that, they work out the index. So suppose the hospital index, one particular case, 0.85.
Right.
So the reimbursement will be 100 into 1, that is 85 rupees. That means 50 rupees will be cut.
Right.
Similarly, for example, they have clinical outcomes. For example, surgical site infection, they are very particular about it. So they will get through technology. The question in India is how do we capture these surgical site infection? So nowadays, through technology sensors, we can actually find out what is the surgical site infection. Okay, what is the UTI? All these parameters we compositely come as a clinical indicator.
Right.
Suppose clinical indicator again is 0.9, so the payment will be 0.9. So 0.9 into 0.85. So the hospital perforce
will have to improve the quality.
Now
So
in India you want to do it. Suppose now you are saying, now you can't do it if the hospital is not even accredited. They will not even understand what is surgical site infection. How do I do it?
right.
So you have to first increase the number of accreditation, number of certification in India, and then enforce this. What you are saying,
Right.
pay for performance. What we call it, pay for performance. So government today is payer, and payer can impose that I will not pay you the money unless I get the measurement on service quality and clinical quality.
Or maybe get higher payment if you exceed the requirement.
Incentivized.
So in US they measure, after organ transplant they measure 1 year, 5 year, 10 year survival rates, hospital acquired infection rates, hospital falls, bed sores, readmission rates.
Correct.
You underwent a surgery and if you get readmitted within a short time,
It is cut.
obviously your surgery did not go well and your infection rates were very high.
Already they have started talking in the
Yes.
Ayushman Bharat, but let me tell you, practically it will take some more time before we are able to
But
really.
at least the
Thought process.
Ayushman Bharat,
Yes.
we started even the onboarding of hospitals is based on certain parameters.
Yes.
Maybe tomorrow the hospitals which are not there as part of Ayushman Bharat, because a lot of small hospitals want to be part of Ayushman Bharat, but they do not have the required infrastructure or clinical excellence. And they have a lot of spare capacity. Their beds are free, ICUs are free, their OTs are not running optimally, and other value-added services also, which can generate additional revenue for the hospital and improve its profitability, while also servicing larger number of patients across the country. Right. So this has been a fantastic discussion with you, Dr. Gyani, and your industry experience is visible through what we are really discussing. So, as a parting shot, what would be your advice? You had a sterling career, and what would be your advice to the new generation of leaders?
Okay. On the leaders, I always quote one thing. I had opportunity to work with Dr. Abdul Kalam on few occasions, and 2 occasions very intimately. So
One of the very fine leaders.
he used to tell me this number of times.
Right.
That leader is the one who creates leaders,
Right.
and the good leader is the one who creates leaders who can outshine him.
Right.
I think the message to our generation is that we have to empower our younger colleagues so they become better than us. We should be very magnanimous in that, number one. Number two, we have to empower these youngsters. And today's generation is very sharp, let me tell you. Their IQ is much higher than what IQ was in our age. So if we can really show them that this is the India which we can make,
Right.
present a big picture to them, naturally they will like to be part of it. So our job is only to show them that big picture, because we can show them, because we have some element of wisdom at generation. So if we can really show them, they are really ready to jump in. In fact, I again can quote you something, General Malik Shah, for example. He came to Jaipur where I was there, So he was addressing in the big auditorium, more than 1,000 people. So somebody told him that India is in productivity around, I think, 38 out of 42 countries that time. The productivity was so low. So what do you suggest? So he started laughing. He said, "You are very lucky people here. You are in 38th position, you cannot go down now. You can only go up.
Absolutely.
So I think that was the way Manik used to, you know, of course, you know. So I think something similar we have to tell our people. That now, of course, we are in a good position, but if we have to become second largest economy or third largest economy, I think they will like to be part of it.
Right. And we have a major demographic advantage. We are among one of the youngest countries, you know, the average age is around 28. And this demographic advantage to India is going to last for another 15 to 20 years. And that's when we are really looking forward to hitting among the top 2 or number 1 spot in terms of growth. If we sustain the current rate of GDP growth year on year. So thank you so much, Dr. Gyani, for such critical insights. It's been a pleasure speaking with you. Thank you for your valuable time.
Thank you.
And thank you for listening, dear viewers. We'll be soon back with another fantastic session for you all. Thank you.
Thank you.